Okay, as we have seen earlier, there is the function. What is the function of the stomach? So, it main function is to store the food temporarily, as it can be ingested more rapidly then it can be digested. Okay, then chemically and mechanically digest food using acid enzymes and the uh, churning movement. Okay, using acid enzyme and the churning movement, then uh, regulate the release of resulting chyme into the small intestine. Okay, regulate the release of chyme into the small intestine, then secrete intrinsic factor, which is essential for the absorption of the vitamin B12. Secrete the intrinsic factor, which is essential for the absorption of vitamin B12. Okay, gastric cells, cell type and the function. So, the gastric cells are the parietal cells, chief cell, G cell, enterochromaffin cells, and the surface mucous cell. Okay, so the parietal cell will secrete the HCl and the intrinsic factor. Okay, the chief cell will secrete the pepsinogen. G cell will secrete the gastrin. Enterochromaffin cell will secrete the histamine, and the surface mucous cell will secrete the mucus. Okay, this is easy. Mucus cell to mucus, then the G cell to gastrin. Okay, uh, then parietal cells will secrete the HCl and the intrinsic factor. Okay, so parietal cells will secrete the HCl and the intrinsic factor. Okay, and the uh, chief is the Pepsi. So the chief cell will secrete the pepsinogen, and the parietal cell will secrete the HCl and the intrinsic factor. So this is the PHI. Okay, parietal cell will secrete the HCl and the intrinsic factor. Chief cell will secrete the pepsinogen, and G cell will secrete the gastrin. Enterochromaffin cell will secrete the histamine. Okay, enterochromaffin cell will secrete the histamine. This way have to remember. Okay, and the surface mucous cell will secrete the mucus. Now, gastric acid. So, the acid environment in the stomach provides a defense mechanism against ingested microorganisms. Okay, the acid environment in the stomach provides a defense mechanism against the ingested microorganism. Aids protein digestion by activation of the pepsinogen and denaturation of dietary protein, and stimulate the flow of bile and pancreatic juice. Okay, acid environment will in the stomach provide defense mechanism against the microorganism, then aid protein digestion by the activation of the pepsinogen. Protein digestion by activation of the pepsinogen will cause the protein digestion by activation of the pepsinogen. Okay, it occur by the gastric acid. Okay, and denaturation of dietary protein. Denaturation of the dietary protein and denaturation of the dietary protein and stimulation of stimulates the flow of bile and pancreatic juice. Stimulates the flow of bile and the pancreatic juice. It is stimulated by the gastric acid. Okay, it causes activation of the pepsinogen. Okay, and causes the denaturation of the dietary protein. Then mechanism of secretion. So in the parietal cells, CO2 and HCO2 are converted into the H plus and the HCO3 minus, catalyzed by the carbonic anhydrase. The H plus is secreted into the lumen of the stomach in exchange of the potassium by the H plus K plus ATPase pump, proton pump, on the apical membrane of the parietal cells. Chloride is secreted along with the hydrogen. Thus, the secretion product of the parietal cell is HCl. Okay, so as we have seen that the CO2 and the HCO2 are converted to the H plus and the HCO3 minus, okay, in the parietal cells. Then the this H plus is secreted into the lumen of the stomach in exchange for the potassium by the H plus K plus ATPase proton pump, okay, and the chloride is secreted along with the hydrogen, so the HCl is secreted. Okay, the HCO3 minus produced in the cell is absorbed into the bloodstream in exchange for chloride. Okay, chloride HCO3 minus exchange, okay, across the basolateral membrane. Eventually this HCO3 minus will be secreted in the pancreatic secretion to neutralize the H plus in the small intestine. Okay, this bicarb will secreted into the pancreatic secretion, will and to neutralize the hydrogen ion in the intestine, in the small intestine. Okay, then factors stimulating the secretion. Okay, factors that stimulate the secretion of the gastric acid. So the secretion of the HCl is stimulated by the vagal stimulation. Okay, secretion of the HCl is stimulated by the vagal stimulation. Okay, directly through the neurotransmitter acetylcholine acting at the muscarinic receptor on the parietal cell. Okay, vagal stimulation directly through the neurotransmitter acetylcholine acting at the muscarinic M3 receptor on the parietal cells. Okay, vagal stimulation directly through the neurotransmitter acetylcholine help to stimulate the secretion of the HCl. Is the vagal stimulation directly through the neurotransmitter acetylcholine. Okay, acting at the muscarinic M3 receptor of the parietal cells. Okay, M3 receptor of the parietal cells. Okay, neurotransmitter acetylcholine due to vagal stimulation. Okay, indirectly through the neurotransmitter gastrin releasing peptide GRP, stimulating release of the gastrin from the G cells. Stimulating release of the gastrin from the G cells indirectly through the neurotransmitter gastrin releasing peptide GRP. Okay, and it will stimulate the gastrin from the G cells. Then the histamine acting at the H2 receptor on the parietal cells. Histamine acting on the H2 receptor on the parietal cells, released from the enterochromaffin like cells. Okay, enterochromaffin like cells will secrete the histamine, and histamine will act at the H2 receptor on the parietal cells in response to vagal activity and the gastrin. Gastrin released from the antral G cell acting at the CCKB, cholecystokinin binding receptor on the parietal cells. Okay, so the histamine, the gastrin, and the neurotransmitter acetylcholine, they all will somehow increase the secretion of the HCl in the parietal cells. Okay, acetylcholine will act on the muscarinic receptor of the parietal cells and secrete the HCl. Then the gastrin is stimulated by the neurotransmitter gastrin releasing peptide, and this gastrin secretion from the G cell will act on the CCKB receptor in the parietal cell and will secrete the HCl. The histamine acting at the H2 receptor, which is uh, secreted by the enterochromaffin like cells, and will cause the secretion of the parietal cells. Okay, factors inhibiting the secretion. So the secretion of the HCl is inhibited by the low pH of less than 3 in the stomach, then the prostaglandin, somatostatin, both directly through the inhibition of the parietal cell and indirectly through the inhibition of the gastrin and histamine release. Okay, then prostaglandin and the pH less than 3. Then enterogastrons like secretin gastrin inhibitory peptide and the cholecystokinin. Okay, then the vagotomy and drugs like H2 receptor blocker, cimetidine, then the proton pump inhibitor like the omeprazole and the muscarinic receptor antagonist like the atropine. Okay, H2 receptor blocker like the cimetidine, then the proton pump inhibitor like the omeprazole and the muscarinic receptor antagonist like the atropine. These are the inhibitor of the gastric acid secretion. Then gastric emptying. So gastric emptying. Okay, we'll see in this the gastric motility, gastric emptying. Okay, and then we'll see the gastric fuse. So in the gastric emptying, mixing of the food with the gastric secretions takes place in the distal body. Okay, mixing of the food with the gastric secretion will take place in the distal body and the antrum. Okay, so this is the stomach. Okay, so this is the distal body and this is the antrum. So the mixing of the food with the gastric secretion will occur here of the stomach where the muscarinic where the muscularis externa layer is thicker. Okay, whereas the muscularis external layer is thicker, the stomach has an additional inner oblique smooth muscle. Okay, stomach has an uh, additional inner oblique smooth muscle layer in addition to the inner circular layer and the outer longitudinal layer. Okay, has the inner oblique layer, oblique smooth muscle layer. Okay, and the outer longitudinal layer. Okay, allowing peristaltic contraction and through mixing and thorough mixing. Then the gastric contractions are increased by the vagal stimulation. Okay, thorough mixing. The gastric contraction are increased by the vagal stimulation, allowing peristaltic contraction. Okay, and the thorough mixing. Gastric contraction are increased by the vagal stimulation and the decreased by the sympathetic stimulation. Okay, contraction is increased by the vagal stimulation and decreased by the sympathetic stimulation. Gastric motility or the mixing. Then gastric emptying. So the presence of chyme in the pyloric antrum distends it and cause the antral contraction and opening of the pyloric sphincter. Okay, the presence of chyme in the pyloric antrum will distend it and cause antral contraction and the pyloric sphincter opening. The rate of the gastric emptying is regulated, which leads to precise supply of chyme to the intestine. Okay, which leads to precise supply of chyme, leads to supply of chyme to the intestine. Okay, supply of chyme to the intestine at an appropriate rate of the digestion. Gastric emptying varies with different food type. Carbohydrates are emptied more quickly, protein more slowly, and fatty foods even more so. Liquids empty more rapidly than the solid food. Okay, carbohydrate will faster emptied than the then protein will empty and the fatty food will very slow emptied, and the liquid will empty more faster than the solid. Okay. Then gastric emptying is increased by the distension of the pyloric antrum. Okay. Fall in the pH of chyme in the stomach, fall in the pH of chyme in the stomach. Then the parasympathetic stimulation. Okay. The gastric emptying is decreased by uh, enterogastric inhibitory reflex is stimulated by enterogastric inhibitory reflex. Okay. Enterogastric inhibitory reflex is stimulated by gastric emptying is decreased. How it decreases? Enterogastric inhibitory reflexes. Okay. uh, which is stimulated by the distension of the duodenum. Okay. Distension of the duodenum. Okay. Then the presence of fat in the duodenum by stimulating release of the cholecystokinin. Fall in the pH of chyme in the duodenum, and increase in osmolality of the chyme in the duodenum. Then irritation of the mucosal lining of the duodenum. Okay, distension of the duodenum. Then the presence of fat into the duodenum, fall in the pH of chyme. Okay. Into the duodenum. Then increased osmolarity and the irritation of the mucosal lining of the duodenum. Anything done in the duodenum will cause a decrease in the uh, emptying of the stomach gastric content. Okay. Then hormones. So the cholecystokinin and the secretin. Okay, will decrease the emptying. Cholecystokinin and the secretin. Gastric emptying can also be delayed pathologically by the mechanical obstruction. Okay. Tumor or stenosis, or by non-mechanical causes myotonic dystrophy or autonomic neuropathy. Okay. Myotonic dystrophy or the autonomic neuropathy or mechanical obstruction like tumor and the stenosis, okay, will cause decrease the gastric emptying. Then gastric juice. So the average adult produces 2 to 3 liter of the gastric fluid every 24 hours. The average adult produce 2 to 3 liter of the gastric fluid every 24 hours. Gastric fluid contains mucus, HCl, digestive enzymes like pepsinogen, gastric lipase, and the intrinsic factor. Okay, right. Gastric fluid will contain the mucus, HCl, digestive enzymes like pepsinogen, gastric lipase, and the intrinsic factor. The mucus, we see all the things, all the contents of the gastric fluid in detail. So the mucus is secreted by the surface mucous cell. The alkaline mucin-rich fluid form a water insoluble gel. Forms a water insoluble gel. Okay, it is the alkaline and mucin-rich fluid. Okay, it's a water insoluble gel that adhere to the surface of the stomach lumen. Okay, and it plays an important role in the protection of the stomach against its acid content and autodigestion by the pepsin. Okay. It causes the important role in the protection of the stomach, okay, against its acid content. Okay, and autodigestion by the pepsin. In addition, local mediators such as prostaglandin are released when the mucus is irritated. Okay, prostaglandin are released when the mucus is irritated, and this increase the thickness of the mucus layer and stimulate the production of the bicarb, which neutralize the acid. Okay, when sometimes the mucus is irritated, the prostaglandin, okay, is uh, secreted, and this increase the thickness of the mucus layer and stimulate the production of the bicarb, which neutralize the acid. Okay. Then HCl. HCl is secreted by the gastric parietal cells. Then the digestive enzyme, proteins in the food are broken down and the polypeptide into the polypeptide in the stomach by the enzyme called the pepsinogen. Okay, by pepsinogen the protein will converted into the polypeptide. Okay, pepsin is secreted in the form of its inactive precursor, okay, pepsinogen, from the chief cell in the gastric mucosa. Okay, pepsin is secreted in the form of inactive precursor. Okay, pepsin is secreted in the inactive precursor in the pepsinogen precursor, the pepsinogen from the chief cell. Okay, from the chief cell, pepsinogen is secreted and then it converted into the pepsin. Okay, and it do the protein digestion into the polypeptide. Okay, okay, and is converted into its active form by the acid environment of the stomach. Okay, now gastric lipase is of little physiological importance except in pancreatic insufficiency. Okay, gastric lipase is of little physiological importance except in the pancreatic insufficiency. Okay, then the intrinsic factor. Intrinsic factor is produced by the parietal cells. Okay, intrinsic factor is produced by the parietal cells. Okay, and is essential for the vitamin B12 absorption. Intrinsic factor is secreted by the parietal cells and is essential for the absorption of the B12. Okay, intrinsic factor bind to vitamin B12, allowing it to escape degradation in the stomach and intestine. Okay, and to be safely transported to the terminal ileum where it is absorbed. Okay, from the intestine and the stomach, its degradation is inhibited by the intrinsic factor and is safely transported to the terminal ileum and where it is absorbed. Okay, then the gastric mucosal barrier mechanism. Gastric mucosal barrier mechanism. So what we have seen here, we will see here that the mechanism of the mechanism to protect the gastric mucosa, mechanism to protect the gastric mucosa, then the clinical importance. Okay, only these are there. So mechanism: secretion of mucus by the mucous neck cells and the goblet cell, which form the water insoluble gel that coat the gastric mucosa, protecting it from the gastric acid, from the acidic gastric content, and autodigestion by the pepsin. Okay, secretion of bicarb by surface epithelial cells which form. Okay, so the mucus and the bicarb by the surface epithelial cell which form part of the mucosal gel layer, rising the pH around the mucus layer. Okay, compact epithelium lining with tight junction between cell and fast cell turnover. Okay, compact epithelium lining which tight junctions between the cell and the fast cell turnover. Okay, the production of the prostaglandin which inhibit acid secretion. Production of the prostaglandin, okay, that inhibit the acid secretion, increase the mucus and the HCO3 secretion and the IgA secretion, which helps prevent against the invasive invasion by ingested microorganisms. Okay, the IgA, it also helps prevent against the invasion by the ingested microorganism. Then the clinical implication: mucosal protection may be impaired by Okay, how this mucosal protection is impaired. So the exchange, so the excess acid secretion, that's the Zollinger-Ellison syndrome. Then the NSAIDs, which inhibit the prostaglandin production. Okay, excess uh, acid secretion will be on axis. That's the Zollinger-Ellison syndrome. Then the NSAIDs, non-steroidal anti-inflammatory drug, which inhibit the prostaglandin production and hence reduce the mucus secretion. Then the Helicobacter pylori infection, H. pylori infection. Then the hypercalcemia, alcohol, and the chronic nicotine exposure in smoking. Okay, chronic nicotine exposure in smoking, then the alcohol, then the hypercalcemia, H. pylori infection, NSAIDs, which inhibit the prostaglandin production and hence reduce the mucus secretion. Okay, and the Zollinger-Ellison syndrome. Okay, H. pylori infection, hypercalcemia, alcohol, and the nicotine. This all will cause the gastric mucosal barrier to impaired. Then we'll see the gastrin. Okay, in gastrin, there is the stimulating factor, inhibiting factor, and the function. Okay, so gastrin is secreted by the antral G cells and acts on the cholecystokinin B receptor. Okay, stimulating factor of the gastrin. So the gastrin secretion is stimulated by the presence of small peptides and amino acids in the chyme. Then gastrin distension. Okay, gastric distension. Then the vagal stimulation directly via acetylcholine and indirectly via the gastrin releasing peptide. Okay, vagal stimulation, gastric distension, small peptides and the amino acids in the chyme. Then the vagal stimulation directly via acetylcholine and indirectly via the gastrin releasing peptide. Okay, raised gastric pH. Okay, so this will secrete the gastrin and inhibiting factor. So gastrin secretion is inhibited by the low gastric pH. Okay, when the pH is low, then the somatostatin, secretin, gastric inhibitory peptide, and the cholecystokinin. Okay, so the gastrin is secreted by the antral G cells and act on the cholecystokinin B receptor. When it's stimulated? It's stimulated when the amino acid and the peptide in the chyme. Okay, gastric distension. So the gastrin will act to stimulate the acid secretion from the gastric parietal cells. Okay, it stimulate the pepsinogen from the gastric chief cells, stimulate pepsinogen, then the increase the gastric motility and stimulate the growth of gastric mucosa. So it increase the gastric acid. When there is the pH is high, that means the acidity will be low. It causes the increased gastric secretion. Okay, vagal stimulation via the acetylcholine and indirectly via the gastrin releasing peptide. When the gastric is distended, gastrin will be secreted. Okay, and when it's inhibited, so it's inhibited when the acidity is very high, then the somatostatin, secretin, gastrin inhibitory polypeptide, and the cholecystokinin. Okay, function. The gastrin act to stimulate acid secretion from the parietal cells. Okay, both directly and indirectly, stimulating release of histamine from the ECL cells. Then the stimulate pepsinogen secretion from the chief cell. Okay, pepsinogen secretion from the chief cells increase gastric motility and stimulate growth of gastric mucosa. Okay, so just we look here that the gastrin G cell in the release from the G cell in the pyloric antrum. Okay, it's stimulated by the as we have seen earlier. Then the cholecystokinin. Cholecystokinin is will released from the eye cells in the duodenum and the jejunum. Its presence of it stimulated by the presence of fatty acids, monoglyceride, peptide, and amino acid. As this all we have seen. Then the secretin and the gastrin inhibitory peptide. Okay, secreted by the S cells of the duodenum. Its stimulation occur when the pH is low, means there is acidic medium and the presence of fatty acids in the duodenum, and it's inhibited by the somatostatin. This all we have seen earlier, and last one is the gastric inhibitory peptide. Now the iron handling. Okay, so the iron handling occur in the small intestine, but what we will see here, so the iron absorption, then the iron transport, regulation of the iron absorption. Okay, this only we will see here. The total amount of the iron in the body is about 3 to 4 gram. Okay, the total amount of iron in the body is 3 to 4 gram, which about two-third of in is in the hemoglobin. The two-third part of this 3 to 4 gram is in the hemoglobin. Okay, iron absorption. So iron exists in two forms: the ferrous state Fe plus 2 or the ferric state the Fe plus 3. Okay, the most dietary iron is in the ferric state. Okay, which is reduced by uh, ferry reductase. Okay, in the mucosa. Okay, which is reduced by the ferry reductase. Okay, this ferric state is reduced by the ferry reductase in the mucosa, assisted by the ascorbic acid in the mucosa, and it's assisted by the ascorbic acid. Okay, and HCl in the gastric secretion to more soluble ferrous. Okay, and then absorbed by the duodenum and the jejunum. Okay, so there are two forms of the iron: ferrous Fe plus 2 and the ferric Fe plus 3. Most dietary iron are in the ferric form, so this ferric form is converted into mucosa by the ascorbic acid and the HCl. Okay, in gastric secretion, and it converted to the ferrous, and then this will absorb into the duodenum and the jejunum. Okay, Fe plus 2 is taken across the enterocyte. Okay, Fe plus 2 ferrous is taken into the enterocyte apical membrane by the divalent metal transport. Okay, divalent metal transport. It will uh, in the enterocyte taken across the enterocyte apical membrane by the divalent metal transport DMT1. Okay, in the uh, enterocyte Fe plus 2 is oxidized to the Fe plus 3. Okay, in the enterocyte ferrous is oxidized to the ferric. Okay, and then either stored in the electrocyte, enterocyte epithelial cells bound to the apoferritin or released into the plasma via the molecule ferroportin on the basolateral membrane. Okay, this Fe plus 2 is taken across the enterocyte. Okay, this enterocyte Fe plus 2 will be there. Okay, and in the enterocyte by the divalent metal transport. Okay, then in the enterocyte Fe plus 2 is oxidized to the Fe plus 3. Okay, this will converted into the Fe plus 3. Okay, is oxidized to this, and then it either stored in the into the enterocyte or will be released into the plasma, and by the molecule of ferroportin on the basolateral membrane. Then the ion transport. Ion is in the plasma is bound to the transport protein transferrin. Okay. Okay, as we have seen here, either stored in the enterocyte epithelial cells bound to the apoferritin or released into the plasma molecule ferroportin. Okay, apoferritin and the ferroportin. Okay, then transport protein via the transferrin. Okay, iron is transferred to the bone marrow for erythropoiesis. Okay, transferred to the bone marrow for the erythropoiesis or to the liver or other parenchymal cells. Okay, for storage as ferritin or hemosiderin. Okay, it will transfer to the bone marrow for the hemopoiesis, erythropoiesis, or to the liver or other parenchymal cells for storage as ferritin or hemosiderin. Okay, storage as the ferritin or the hemosiderin. The iron released from the breakdown of senescent red blood cell. Okay, iron is released by the breakdown of the RBC, some of which is stored by the macrophages in the liver and spleen, and provides most of the iron on transferrin. Okay, only a small proportion of the transferrin ion comes from dietary iron. Okay, by the breakdown of the RBC, this iron is released and it's stored into the macrophages in the uh, liver and spleen, and provides most of the iron on the transferrin. Okay, only small portion of transferrin iron comes from the dietary iron. Okay, then the regulation of the iron absorption. So the normal western diet contains about 10 to 20 milligram of iron. Okay, 10 to 20 mg of iron per day, and typically about 5 to 10 percentage of this is absorbed. Okay, to replace this that lost by intestinal epithelial cell shedding, iron iron absorption is tightly reduced as excess iron is potentially toxic. Okay, and the body has no physiological mechanism for upregulating excretion. Okay, the normal western diet contains 10 to 20 mg of iron per day. Okay, uh, this is of this the 5 to 10 percentage of is absorbed. Iron absorption is tightly regulated as excess iron is potentially toxic. Okay, excess iron is toxic, and the body has no physiological mechanism for upregulation of excretion. Iron absorption can be increased when body stores are low. Okay, or when there is a need to increase the erythropoiesis, that is increase in the absorption may be seen in 3 to 4 days following the hemorrhage. Okay, then hepcidin is the main hormonal regulator. Hepcidin is the main hormonal regulator of iron hemostasis. Okay, hepcidin is the main hormonal regulator of the iron homeostasis. It inhibits iron release from the macrophages in the reticuloendothelial system and from the intestinal epithelial cells, and inhibits intestinal iron absorption. Hepcidin is suppressed by the erythropoietin, infective erythropoiesis, pregnancy, and the hypoxia, but regulated in the inflammation and iron overdose. Okay, hepcidin is the main hormonal regulator of iron homeostasis. Okay, hepcidin is the main hormonal regulator of the iron homeostasis. It inhibits the release of the iron release from the macrophages in the reticuloendothelial system. Okay, and from the intestinal epithelial cells, and inhibit the intestinal iron absorption. Okay, inhibit the intestinal iron absorption. Hepcidin is suppressed by the erythropoietin, uh, ineffective erythropoiesis, pregnancy, and the hypoxia, but upregulated in the inflammation and the iron overload.